Good morning, students. Today we'll be discussing short notes, subject periodontology for the year 2020. We'll be discussing chlorhexidine today. Question paper is given here on the screen. We'll be starting with the chlorhexidine. Chlorhexidine. History. Chlorhexidine was developed by Imperial Chemical Industries in England during 1940s. It was marketed as general antiseptic in the year 1950. A definitive study for caries inhibition by inhibition of dental plaque was done by Lowe and Scheidt in 1972. Structure. It is bis-biguanide antiseptic, a symmetrical molecule consisting of 4 chlorophenyl ring and 2 biguanide group connected by central hexamethylene bridge. Chlorhexidine is available in 3 forms: digluconate, that is water soluble; acetate, water soluble; hydrochloride salt, poorly soluble in water. Characteristic. Chlorhexidine is an antimicrobial agent, strong base, dicatinic at pH level above 3.5 with 2 positive charges. It prevents plaque accumulation, hence it is anti-plaque and anti-gingivitis agent. It can be bacteriostatic at the concentration of 0.02 to 0.06 or bactericidal at the concentration of 0.2 to 0.12 depending upon the concentration. Success of chlorhexidine. Efficacy. Chlorhexidine is bactericidal against gram-positive and gram-negative bacteria and yeast such as those responsible for oral candidiasis. Substantivity. Chlorhexidine binds with the hard and soft tissues in the oral cavity and is slowly released over time in a concentration that is bactericidal. The superior anti-plaque effect of chlorhexidine, which make it gold standard, can be attributed to its substantivity. Safety. Chlorhexidine seems to have very low level of toxicity and shows no permanent retention in the body. Mechanism of action. As we have already discussed, depending upon the concentration, it is either bacteriostatic or bactericidal. Bacteriostatic means at a low concentration, it will be altering the osmotic balance of the bacterial cell. It promotes release of low molecular weight molecules like potassium and phosphorus, but still bacteria will not be killed. Bactericidal, that means the bacteria will be killed on the high concentration of chlorhexidine. The chlorhexidine causes cell death by cytolysis. Its ability to increase the permeability of bacterial cell membrane, resulting in the release of main intercellular component including potassium, thereby altering the cell protein structure, causing the precipitation or coagulation of cytoplasmic proteins. As we have shown this in the diagram. This is a chlorhexidine molecule. The positive charge chlorhexidine molecule is attached to the negative charge phosphate group on microbial cell wall. Once it is attached onto the surface of bacterial cell wall, chlorhexidine increases permeability of the cell membrane. It increases the permeability of cell membrane. Various pores are being formed in the cell membrane through which the component of the cell will leak out and the cell will die by process of cell lysis. Action of chlorhexidine. An influence on pellicle formation will be there by blocking the acidic group on the salivary glycoprotein, thus reducing the protein adsorption on the tooth surface. An influence on adsorption of plaque onto the tooth surface by binding to bacteria in sublethal amount. Next, influence on the formation of plaque. So chlorhexidine is influencing the pellicle formation. It is influencing the adsorption of plaque onto the tooth surface as well as formation of plaque by precipitation, precipitating the agglutinating factor in the saliva and displacing the calcium from the plaque matrix. Various formulations of chlorhexidine mouth rinse. Chlorhexidine mouth rinse are available in the form of 0.2% and 0.12%. There is equal efficacy of 0.2 and 0.12% rinse when used at appropriate similar dose. After rinsing with 10 ml of 0.2% aqueous solution of chlorhexidine for 1 minute. Approximately 30% of the drug is retained back in the oral cavity. Pin cushion effect. One charged end of chlorhexidine molecule bind to the tooth surface and the other remaining available to interact with the bacterial membrane as microorganism approaches the tooth surface. This is known as pin cushion effect. Ideal regime is twice daily, morning and night, which will have a substantivity for 12 hours. Clinical application as adjunct to oral hygiene and professional prophylaxis, post-oral surgery, and in periodontal surgeries or root planning, patient with intermaxillary fixation and in patients who are under high risk of caries. Physically and mentally handicapped, chlorhexidine spray can be used. Medically compromised patient. Subgingival irrigation, final irrigation before root canal obturation, management of denture stomatitis, hypersensitivity, tooth decay, recurrent oral ulceration, patient undergoing orthodontic treatment, oral malodor for surgical skin preparation, and in perio as a local drug delivery system in the form of biodegradable chip that can be used subgingivally. For example, perio chip 2.5 mg of chlorhexidine is found to have average drug concentration that is greater than 125 microgram per milliliter for 7 to 10 days. Side effect: brown discoloration of the teeth, restorative material, and as well as yellow discoloration of the tongue. So discoloration will be there on the teeth as well as other restorative material. Unusual or unpleasant taste in the mouth, decreased taste sensation, oral mucosal erosion, enhanced supragingival calculus formation and parotid gland swelling. Limitation: teratogenic effect, neurosensory deafness, which can occur if chlorhexidine is introduced into the middle layer. Because many drugs are excreted in human milk, caution might be indicated when chlorhexidine is administered to nursing women. Bacterial resistance. Resistance has not been reported even in long-term oral use. Allergic reactions has been reported with chlorhexidine. Thank you.